Hi, everybody. Welcome back. We're going to get started here with Dr. Gandhi, who's going to be giving us an update on COVID. And I just want to kind of make a quick comment that what's also nice about this format is that people can kind of come in and come out, especially for our panelists. And we're going to be having Dr. Hoy join us from Australia, where it's about, 5 in the morning there right now. So she'll be just waking up and will have fresh comments for us. So, Dr. Gandhi, over to you.
So over the next few minutes, I'm going to talk about COVID, and it's an impossible task to try to update everything about COVID. So I'll focus mostly on treatment of COVID, and near the end, I will come back to the intersection of HIV and COVID, which we've been really touching on throughout today. So let's go ahead and get started. I like to term this the multi-dimensional challenge of COVID-19. For those of you who remember the original Star Trek, this is Spock playing three-dimensional chess, and I really think COVID is a multi-dimensional challenge. So let's put this into some context. So COVID, of course, has its clinical manifestations, primarily a respiratory illness, but as we'll see, it's a multi-system disease as well. And we'll delve into a little bit of a concept of thromboinflammation. A lot of COVID treatment, of course, depends on stage and severity of disease, and we'll talk about early versus late disease, and we'll talk about the varying severities of disease. And I'll include some data that was just published in the New England Journal last night that pertains to this. And then the intervention, in particular, antivirals, immunomodulators, combination therapies, etc., will be touched on in the next few minutes. So a word about clinical manifestations. The classic symptoms of COVID, of course, are fever, cough, sore throat, myalgias, and malaise. Gastrointestinal symptoms can be prominent, anorexia, nausea, and diarrhea. Taste and smell disturbances happen in about a quarter of people and do seem to be more common in women than in men. Shortness of breath is a harbinger or a kind of a portend of worse outcome. It can happen somewhere between 5 to 8 days after symptom onset, and it can be an indicator that people are declining into what we sometimes call severe disease. Laboratory findings include lymphopenia, elevated D-dimer, LDH, CRP, ferritin, liver enzymes, and interleukin-6, particularly in the severe manifestation in the hospitalized individuals. Here are some of the classic radiographic features of COVID. They could be quite pleiotropic, but peripheral, bilateral, ground glass opacities with or without consolidation. And this CT shows you, I think, one of the best examples of those rounded morphologies in the peripheral lung fields that can be part and parcel of the COVID presentation. So I alluded to the fact that although it's a respiratory illness, pretty much every single organ system can be involved, similar in many ways to HIV. People can present with neurologic syndromes such as stroke, cardiovascular disease. We've seen a number of cases of myocarditis. We'll talk about that briefly. Renal failure, gastrointestinal problems, not only symptoms, but elevated liver function tests. The famous cutaneous manifestations, which I'll show you a picture of, the COVID toes. And then it is a systemic disease, one severe, and we'll talk about the concept of thromboinflammation, but coagulopathies are prominent when people get critically ill with COVID. So you've all probably heard about or seen this COVID toes. These are erythematous to violaceous macules, papules, papulonodules. Sometimes you can get pseudovesiculation at the tips of the digits and the soles of the feet. Not entirely clear as to what causes this. It might be a peri-infectious or a post-infectious phenomenon, still being defined in terms of its pathology. The cardiac manifestations, some of our most severe cases have been acute cardiac injury with elevated troponins, sometimes young people presenting with heart failure and cardiogenic shock, myocarditis, arrhythmias, and then thrombosis. So this entity of thromboinflammation is really, once severe, really one of the hallmarks of COVID-19. From the very early days of COVID, associations have been made between not only inflammatory markers, but also coagulation biomarkers and mortality. So if you look at things like D-dimer, IL-6, the survivors of COVID, which are in blue, have much lower levels of these inflammatory and thrombotic markers than the non-survivors. It's thought that the inflammatory response itself may injure the endothelium and lead to a coagulopathy. And then you can get complications such as pulmonary emboli, myocardial infarction, and disseminated intravascular coagulation. Now, a pathology study that came out relatively early in the COVID era, but I still find very, insightful, is a comparison of lungs from people who died of COVID-19 compared to the lungs on autopsy of people who died of influenza, compared to the lungs of people who died of non-infectious causes. And the lungs from people with COVID, really the hallmark was endothelial injury, widespread thrombosis. The arrows on your right-hand part of the slide point to these alveolar capillary microthrombi, and then this unusual feature of intussusceptive angiogenesis. So with that as background, let's go on to the spectrum of disease, and this is really what has made COVID such a challenge, is it ranges from asymptomatic to pre-symptomatic infection, where people have a positive test for SARS-CoV-2, but no symptoms. How frequent that is somewhat debated. In some literature recently, about 20% of people never develop symptoms, and in other series it can be up to about 40%, but this is obviously people who never develop symptoms are harder to define, and the studies have ranged between 20 to 40%. Mild illness consists of things like fever, cough, sore throat, taste, smell disturbances, but largely no shortness of breath, and abnormal imaging is a little plus minus here, but at least no shortness of breath. Moderate disease, and this is important when we get to treatment, is defined as having an oxygen saturation over 94%, but with evidence of lower respiratory tract disease, whether it be clinical evidence, tachypnea, or imaging findings. And then severe disease from the very early days of COVID is defined as having an oxygen saturation below 94%, or really extensive lung infiltrates. And then finally, critical illness is respiratory failure, shock, multi-organ dysfunction. So data out of China from February showed that of those people who develop symptoms, about 80% have mild to moderate disease, about 15% have severe disease, and about 5% become critically ill. So here are some of the risk factors for severe COVID-19. These are, I think the CDC feels like there's really solid data for the ones on the left-hand side of the slide, so older age in every series that's been looked at. Chronic lung disease, cardiovascular disease, type 2 diabetes, obesity with a BMI of over 30, sickle cell disease, chronic kidney disease, and then immunocompromised states from solid organ transplant. Possible risk factors include pregnancy and other immunocompromised states, and when we get to the last quarter or third of the talk, we'll talk about HIV. What is not also in doubt is not only in the U.S., but really throughout the world, there's been a disproportionate burden of COVID-19 among racial and ethnic minorities, in the U.S., Native Americans, and among the poor. So this is a treatment paradigm that I think puts the severity of disease in context with what we think about the disease pathogenesis. We think in mild disease, the viral replication is prominent just before someone gets symptoms, and in early days of symptoms is when viral replication, or at least nasopharyngeal nasal swabs levels of SARS-CoV-2 tend to be the highest. We think then that will taper off over time, and inflammation certainly seems to be prominent when people get into the severe disease category. And when we get to the treatments and the proven treatments, this will come back to this particular slide. The reason why I like to put this in this context is that will situate the treatments in the different phases. So we think antivirals will likely be most effective in the earlier stages of disease. I'll talk about antibodies because that's where the news is, the latest news has come in, is on antibodies. And then we think that the immunomodulators and the immune suppressants like dexamethasone will fit into the severe critical category. Okay, so here are some of the antiviral targets. Viral entry is through the ACE2 receptor. There's also a host enzyme called TMPRSS2, a drug that's under evaluation, works on these stages. TMPRSS2 is targeted by Camostat. Hydroxychloroquine, which I won't talk about in this talk, unlike many of the other talks I've given, is thought to have an effect on membrane fusion. But I will say the data for hydroxychloroquine, and I'm happy to come back to that later in the Q&A, has not borne out a role for hydroxychloroquine in thus far in any stage of disease, whether it be post-exposure prophylaxis, early disease, or hospitalized patients. Lopinavir-ritonavir is thought to affect the viral protease. And then the drug that I'll talk a bit about now is remdesivir, which is targeting the RNA-dependent RNA polymerase. Okay, so remdesivir. Remdesivir is a nucleotide prodrug and inhibits the viral RNA polymerase and works as a chain terminator. So the study that led to the recent approval of remdesivir is the ACT-1 study, along with some other studies. This was done in hospitalized patients who had lower respiratory tract infection, and they were randomized to get 10 days of intravenous remdesivir or placebo. And the results, the final results, which were just published earlier this month, showed that recovery was more rapid with remdesivir than with placebo, 10 days versus 15 days. So a 5-day improvement on average of recovery. Mortality was 11% in the remdesivir group and 15% in the placebo group, with a hazard ratio of 0.73, which was not statistically significant. There appeared to be a trend, but not statistically significant. The benefit of remdesivir was clearest in those on supplemental oxygen, but who had not yet been intubated. And a manufacturer-sponsored trial called SIMPLE showed that in people with severe COVID-19 who were not yet intubated, 5 days of remdesivir is as good as 10 days of remdesivir. Now, what about in moderate disease? This is a manufacturer-sponsored study of a little under 600 hospitalized patients with moderate disease. As a reminder, pulmonary infiltrates, but O2 sat over 94%. These individuals got equally randomized to remdesivir for 10 days, remdesivir for 5 days, or standard of care. And by day 11, somewhat surprisingly, the 10-day remdesivir group had a similar clinical status as the standard of care group, but the 5-day remdesivir group had a better distribution of clinical status as compared to the standard of care. The authors wrote that this was of uncertain clinical importance. It was a modest effect, but a statistically significant effect. Again, happy to come back to this when we get into the Q&A, but I think in hospitalized patients with moderate disease, I think it's reasonable to decide on remdesivir use on a case-by-case basis. The FDA approval for remdesivir extends to people who are hospitalized with moderate disease, and in my own practice, in someone who has substantial risk factors for worsening, I do use remdesivir in moderate disease, but in someone who might be very young, who is has very few risk factors, often those individuals will get better without any particular antiviral drug. What about solidarity? This, of course, has been a point of much discussion ever since the preprint of the solidarity trial came out recently. Just as a reminder, this is a WHO-sponsored open-label randomized trial that was done in over 30 countries. It involved over 11,000 hospitalized patients. This trial looked at a variety of what they call repurposed antivirals, hydroxychloroquine, remdesivir, lopinavir-ritonavir, and beta-interferon. And none of the study drugs had a definite effect on mortality. The focus has largely been on remdesivir because that's the antiviral that we've been using here in the U.S. More than the other ones that were studied in Solidarity. For remdesivir, where there was a little over 5,000 people in the Solidarity trial, half got remdesivir, half got standard of care, the death rate ratio was 0.95, really not evidence of benefit. So how do we square Solidarity with what we just saw with ACT? I guess it's important to say that Solidarity did not assess time to recovery, whereas ACT did. That was the primary endpoint of ACT. And it is possible that the open-label design of Solidarity may have affected the duration of hospitalization. It's quite clear that people stayed in the hospital in all of the arms in order to get the active agents. Interesting thing that the Solidarity investigators did is they did a meta-analysis of the randomized remdesivir trials, their own trial, which accounted for the bulk of the remdesivir clinical trials experience, as well as ACT and studies from China and the manufacturer studies. And what they saw was interesting, intriguing, which is that the lower risk groups, not on ventilators, had a mortality of 0.8. It was not statistically significant. Their 99% confidence interval was 0.63 to just over 1.01. But in the higher risk groups, there was really no effect of the remdesivir. So how do I interpret this? I think that remdesivir has a clinical effect on recovery, time until recovery. I think it's less clear that it has a mortality benefit, and I think it's not the be-all and end-all of COVID-19 treatment. We need more and better drugs, but I think it has an effect, but not as great of an effect as we had hoped it would have. Let's say a word about convalescent plasma. This has, of course, been in the news. Convalescent plasma, the FDA issued an emergency use authorization for convalescent plasma based on analysis of data from an expanded access program run out of Mayo. This particular EUA was based on a comparison of outcomes among patients who got convalescent plasma with a high titer of neutralizing antibodies to outcomes in patients with a low titer. Overall, there was no difference between the high titer group and the low titer group in 7-day survival. But when they did when a post hoc analysis was done on about 3,000 people out of the 35,000 people, it suggested a benefit of high titer plasma using a different assay in patients who got the plasma within 3 days of diagnosis, who were not intubated, and who were less than 80 years of age. Now, the FDA itself in their EUA and the NIH COVID-19 treatments panels said, and I would agree with this, that because of the lack of a comparison group and the possibility of confounding, convalescent plasma should not be standard of care and that randomized trials should be completed. And the reason the NIH said that and the FDA in their EUA said the same is because it's also possible that with a single-arm expanded access program, that people who got low titer plasma actually had a deleterious effect. And we really need a comparative randomized trial in order to know whether to use this drug or use this intervention. Okay, so the latest intervention that I want to spend a minute about, because this was just published last night in the New England Journal, are monoclonal antibodies. We've all been hearing about this in the news. The monoclonal antibodies that are being talked about are against the SARS-CoV-2 spike protein, and they're being studied for both treatment and prevention. In the publication from last night, in outpatients with mild to moderate disease, so people not in the hospital, not hypoxic, participants were randomized to receive an intravenous infusion of placebo or one of 3 doses of a neutralizing antibody called LY-CoV555. This particular antibody was isolated from the blood of someone who had recovered from COVID-19. So what did they find? First of all, what they're calling it bamlanivimab. I've been practicing that all day. Bamlanivimab. This particular antibody at day 11, the intermediate dose of the antibody appeared to accelerate the decline in viral load, the SARS-CoV-2 viral load. Intriguingly, but I would say not definitively, the frequency of emergency department visit or hospitalization was lower in the antibody groups, the pooled antibody groups. It was 1.6%. Versus 6.3% in the placebo group. And intriguingly, in the higher risk group, people over the age of 65 with obesity, 4% were hospitalized in the antibody group and 15% in the placebo group. And then on your right, part of the graph, you'll see change in symptom score, and that was better in the pooled antibody group than in the placebo group. Diminution in symptoms was greater with the antibody. This trial is ongoing, and actually the AIDS Clinical Trials Group, in a study led by Dr. Davy Smith on the panel, is studying this particular intervention. You may have heard that in hospitalized patients, a different group of individuals, this particular antibody, that study was stopped because in hospitalized patients it didn't appear to be beneficial. But I think, as I keep stressing, there may be important differences as to the timing of when to use these different interventions. And the antibody study in mild to moderate disease that the AIDS Clinical Trial Group and Dr. Smith are leading is very much ongoing and is still enrolling quite briskly. Okay, a word about dexamethasone. Prior to COVID, there has been a lot of controversy over the many years about the use of steroids in viral pneumonia and acute respiratory distress syndrome. But because of that hyperinflammatory state in COVID, steroids were evaluated as a potential intervention. And these are the results of the recovery trial, not to be confused with time to recovery, but the recovery trial, which is a randomized trial among hospitalized patients in the UK. A little over 2,100 people got dexamethasone, over 4,300 got usual care. The overall mortality in all comers was 17% lower. The relative risk of mortality was 0.83. That benefit was really concentrated among people who were on a ventilator or ECMO, where the relative risk of mortality was lowered by 36%, or there was also an important effect on people who were on lower amounts of oxygen, an 18% reduction in mortality. The important point here to always keep in mind is among people who were not on oxygen, there was not only no benefit, but there was a possibility of harm with an increased mortality rate that was not significant, but certainly doesn't support the use of dexamethasone for people who are outpatients or who are not on oxygen. And those people, we should be avoiding dexamethasone if they're not on oxygen. And then a word about interleukin-6 inhibitors. From the early days of COVID, again, interleukin-6 levels have been correlated. High levels of interleukin-6 have been correlated with worse clinical outcomes. There's this concept of a cytokine storm that can occur in severe COVID-19. And in early non-randomized studies, it suggested a possible benefit of inhibiting the IL-6 pathway. There's a very nice editorial that I've updated from JAMA just in the last couple of weeks that puts on a single table that I've adapted here a number of the randomized trials for tocilizumab. So tocilizumab is an interleukin-6 receptor blocker. And here are some of those trials. Some of the trials have shown on some of their endpoints, like death or mechanical ventilation progression or clinical status, some effects of tocilizumab. But I'll draw your attention to the one on the far right. This was done here in Boston, was published in the New England Journal recently. In that particular study, there was no effect of tocilizumab on intubation or death. But I think I'll draw your attention mostly to the last row, the one in red, highlighted in the box red, where mortality really doesn't seem to differ in any of these randomized trials between the tocilizumab versus the comparator group. I would say for now, this is an area to keep your eye on. I think I would not use it in standard practice, but I think the trials, more and more data will come out and we will see where this ends up. But right now, I wouldn't use it outside of a clinical trial. And again, happy to engage in discussion during the Q&A on any of this. Okay, so we'll come back to our treatment spectrum, the stages and severities of disease. And I think what I can say is remdesivir, I do believe, has a role in, let's say, moderate into severe disease. Dexamethasone certainly has a role in severe and especially in critical disease. And hopefully over time, we'll be able to build upon this framework with more and more drugs. One comment here is a lot of what I've been talking about, with the exception of those monoclonal antibodies, have been trials focused on moderate, severe, or critical disease. People in the hospital. Solidarity was in the hospital. Act 1 was in the hospital. Really, but though the bulk of COVID-19 is mild disease and not in the hospital, and that's really why the trials that are focusing on mild to moderate disease, I think, could have a major impact if we can find an intervention that has an effect. And that this point is just making the same point in a visual form, which is we need to move our trials from the right-hand part of the graphic, which is the hospitalized patients, earlier and earlier into the course of disease, which is where the bulk of people with COVID, are living. Okay, so let me summarize this part of the talk with a few points before going on to COVID and HIV. So I think I've hopefully convinced you that COVID treatment requires a multidimensional approach with understanding of the host, the stage and severity of disease, and the intervention. And depending on the host, the stage, severity of disease, therapy may very well differ. Antiviral therapy may be most useful in a different stage than immunomodulators, and then combinations may have a different role altogether. I do also want to draw a couple of lessons from HIV. We all have lived through the pressures to deploy interventions. Certainly in April and March, there was intense pressure to use drugs that turned out later, like hydroxychloroquine, not to have a discernible effect. But I think the lesson of HIV is that we got to temper that pressure to deploy interventions by the importance of finding out if the treatment really works. That was true in HIV in the 1990s, and it's certainly still true with COVID. I think the progress will be much faster with COVID, that iterative process where we build on advances until we get to that tipping point, as we did in 1996 with HIV. That process will be much faster because of the emergency of it, but I think we'll get there the same way as we did with HIV. So in the last few minutes, we'll talk about three questions on COVID-19 and HIV. Is HIV itself a risk factor for severe COVID-19? Do HIV medications have activity against the coronavirus? And one slide on what is the impact of COVID-19 on HIV care and prevention. So is HIV a risk factor for COVID-19? Here's a study out of South Africa that looked at over 3.5 million people in the public sector, adults of whom over 500,000 had HIV. In this particular study, 22,000 people without HIV had COVID-19. I'm sorry, 22,000 people had COVID-19 and were not deceased. There were 625 COVID-19 related deaths. When they looked at the impact of HIV, the hazard ratio for COVID-19 related mortality was about twofold greater. Surprisingly, it was irrespective of viral suppression and immunosuppression. That's a surprise because at least with other respiratory pathogens like influenza, it's really the people with low CD4 counts that have the greatest trouble with those respiratory pathogens. But the authors were careful, and I think this is important, that they can't really rule out residual confounding. For example, they didn't have data on socioeconomic status, which we know impacts COVID-19 outcomes, as well as obesity, which has an effect on COVID-19. Another study that was just presented at the HIV Glasgow, a big meeting in the last couple of weeks, is out of the UK. This is a prospective cohort in the UK of hospitalized patients, over 47,000 of them, of whom 123 had HIV. Overall, the mortality was similar with and without HIV, 27% with HIV, 32% without. But when they did adjustments for other factors that can impact mortality, the mortality turned out to be higher among people with HIV, somewhere between 1.5 to 1.9, so 50 to 90% higher. But then here in the US, this is a study out of the VA that was presented at the AIDS 2020 virtual COVID meeting. This looked at over 30,000 people with HIV, of whom 250 or so had COVID, 76,000 people without HIV, of whom about 500 had COVID. And then when they looked at things like hospitalization, ICU admission, death, really no difference between HIV and COVID. HIV and people without HIV. So I would say right now, the jury is still out. One thing that might be a feature of all these trials, though, is this high rate of comorbidities. These are some data we assembled from Mass General. Between March and April, we identified 36 people with HIV and confirmed COVID, another 11 with probable infections. Like many studies, racial and ethnic minorities were disproportionately impacted. 80% of our patients were racial or ethnic minorities. Our clinic as a whole is about 40% racial or ethnic minorities. But most strikingly, 85% of our patients had some non-HIV comorbidity that put them at risk for severe COVID, obesity, cardiovascular disease, etc. So I think the jury is still out as to whether HIV, independent of other comorbidities, is a risk factor for severe COVID. I think, in my mind, the other comorbidities probably are going to play the dominant role. Do HIV medications have activity against SARS-CoV-2? A word about lopinavir-ritonavir. In vitro, lopinavir-ritonavir inhibits the SARS-CoV protease, and therefore it was used off-label to treat people with COVID. But in a randomized trial in China, there was really no effect of lopinavir-ritonavir on clinical improvement or mortality, but the definitive word is the recovery trial from the UK, as well as the Solidarity trial, which I don't have on this slide. Large trials, no impact of lopinavir-ritonavir on mortality, progression, length of stay. And I think the likely explanation is you need a lot of lopinavir-ritonavir to inhibit the SARS-CoV-2 protease. In one study, you would need to swallow somewhere between 60 to 120 pills of lopinavir-ritonavir to get the levels up to where you inhibit the coronavirus protease. And then the last slide on this topic before we begin to conclude is a study out of Spain that asked the question, in people with HIV, is there some effect of antiretrovirals that they're taking on hospitalization or diagnosis? And in this particular study, they looked at over 77,000 people with HIV, of whom 236 got COVID. And it was intriguing that there was a lower rate of hospitalization in people on TDF-FTC than on TAF-FTC or abacavir-3-TC. But one really important point about this, and the reason why I have not told my patients that there is really an effect of this, is because there could be residual confounding. That is, people who are on TDF-FTC might be younger, or they might have less renal disease than people on TAF-FTC or abacavir-3-TC. And that could be the confounding influence on their COVID outcomes. And so I had a patient ask me this morning, are the drugs that he's on for his HIV protecting him against COVID-19, and I say, really, we have no evidence that they are, and I would take all the same precautions as if you weren't on HIV meds. I don't think the HIV meds are making it more likely that there'll be a problem, but I don't think they're protective either. And then last but not least, what is the impact of COVID-19 on HIV care and prevention? Just one slide, but this could be a whole lecture in and of itself. 2 studies out of the AIDS 2020 meeting, a survey of over 13,000 LGBTI people in over 130 countries. More than a quarter of people with HIV reported difficulty with accessing ART refills. Then a study done here in Boston on looking at PrEP care, substantial disruptions in PrEP care, but most concerningly, the disruptions are disproportionately among vulnerable subpopulations, the young, non-whites, Latinx, and publicly insured. So with that, I'm going to give you my final thoughts. I hope there will be time for some comments and questions. And here are my final thoughts. The disproportionate impact on racial and ethnic minorities of COVID-19 and HIV highlight how disparities drive disparate infectious diseases, and that we must address the structural forces that end these intolerable inequities in healthcare access and outcomes for both HIV and COVID. Second, though, we can't let the COVID-19 pandemic cause us to lose sight of how far we've come in our quest to end the HIV epidemic. As Dr. Del Rio and others were saying, despite the overwhelming need that we all have to respond to COVID-19, we must continue at the same time to move forcefully to end the HIV epidemic here and around the world. So with that, I'm going to stop. Thank you all for your attention. Thank a number of people for contributions to these slides. And I'm going to turn it back over to Mike to see if there's a few minutes for any questions that we have.
Sure. Thanks. That was outstanding, Raj. There are a couple. Let's get to the questions from the audience first. So you mentioned about this increased coagulopathy, and the struggle that I have, I cover a COVID clinic, and there are people who are not in the hospital, but they come in with this sort of nondescript chest pain. They're short of breath. So I check a D-dimer, and it's modestly elevated. So do you use aspirin? Do you use some sort of rivaroxaban, or do you, Lovenox? Yeah. What do you do?
I wish I knew. That's a question that we don't have an answer to. I think right now, in fact, ASH, the American Society of Hematology, just updated their guidelines within the last couple of weeks on COVID. And my read of it is prophylaxis, yes, but these are for hospitalized patients. Prophylaxis, yes. As to whether we go to intermediate or high-dose anticoagulation, I don't think there's a consensus on yet. I think we need to know the answer, especially for those critically ill patients. But I think we just don't know what to do. Yeah. I think the real lesson, though, is to have a very low threshold to think of thromboembolic disease. Again, mostly for your hospitalized patients. Any deterioration, in those people, this is very much in play if they're quite ill. And outpatients, I think it's still a tough one. I don't know. Do you want to give me your thoughts on how you would? What do you do in those people?
If I have a nagging concern, I'll send them for a CT angio and just answer the question, because especially in younger people, we've seen a fair amount of PTE, but it's sporadic. So I haven't been using anything else, not even aspirin, although we are using nonsteroidals, but those are different because they don't inhibit the thromboxanes relative to the cycle.
One thing that might be worth mentioning in hospitalized patients, we did a study in our hospital where we looked at the rate of thromboembolic disease. It was about 7% in people who were hospitalized, but the rate of bleeding was actually about 7% also, serious bleeding. So I think there's still, there's this equipoise going on in hospitalized patients as to whether you do or don't go to that intermediate or high dose, but you definitely have a low threshold to work it up, as you did with your patient.
So Shiva has a question here about CD4 counts and any of the HIV cohorts that have looked at this. Did the CD4 count matter? You mentioned
most of the cohorts.
But what about CD4?
It's a great question. Most of the cohorts, most people are on ART, and a minority of people are with low CD4 count. There was one study that I didn't have time to highlight, but I'll mention now. That was really nicely coordinated out of the University of Missouri. It was a cohort study. And they looked at people with HIV with COVID, and they collected data from all over the country. And what they found is, yes, there was in that particular study worse outcomes in people who had low CD4 counts. So I think that's one bit of data. It's a registry study, it's a cohort study, but I think it's an important study. And so I think, the other studies that I present didn't have enough to really comment, but that registry study, which is in CID not long ago, did find that. So.
Yeah. So we're about out of time for this section, but I think you covered nicely the challenge for all of us. I call it getting sucked into the COVID vortex, where life is just kind of topsy-turvy and every day feels like Wednesday. I can't tell Friday from Monday from Tuesday. But I think that it really is disruptive to our HIV care. And now that we've gotten back to more face-to-face stuff and everyone wearing masks, it seems to be going okay, but it just feels like it's taken our eye off the ball of ending the epidemic and that type of thing. We talked about that a little bit earlier. Well, thank you, Raj. The last word, yeah.
Yeah. Maybe I'll just say that our next session is going to be on HIV and aging, and I think there's no doubt that that's the group where we need to both pay attention about COVID because they're at the greatest risk for COVID, but there's a lot more that we need to do for people who are aging, and so that confluence of our people with HIV who are aging and COVID is another important topic. So maybe that'll be our transition over to the Dr. Hoy, who's going to take us through the last section. The New Yorker has a section called Our Far-Flung Correspondence, and Dr. Hoy is certainly our most far-flung panel member in Australia. She has a clock prominently displayed behind her, and it appears to be reading 7:30 in the morning. Is that right, Dr. Hoy?
Correct. Yep.
Okay. So with that, it's a pleasure to welcome her to talk and lead a panel discussion, I should say, to lead a panel discussion around HIV and aging. Over to you, Dr. Hoy.